A 58-year-old woman presents for a routine follow-up evaluation. She has a history of chronic kidney disease, which has been attributed to systemic lupus erythematosus, or SLE, as well as prior long-term use of non-steroidal anti-inflammatory drugs. In addition, her past medical history is notable for multiple episodes of nephrolithiasis. She underwent natural menopause at the age of 50. At present, her only medication is hydroxychloroquine. She also reports that she stopped smoking 12 years ago following her diagnosis of SLE, and there is no significant family history to note. Now, turning to the laboratory findings, serum calcium is elevated at 11.2 milligrams per deciliter. Albumin is 4.1 grams per deciliter. Creatinine is mildly elevated at 1.5 milligrams per deciliter. Phosphorus is slightly low at 2.7 milligrams per deciliter. Most notably, the parathyroid hormone level is markedly elevated at 720 picograms per milliliter. In addition, dual-energy X-ray absorptiometry, or DXA, demonstrates a T-score of -2.6 at the lumbar spine, which is consistent with osteoporosis. Based on these findings, the question asks, which of the following is the most likely cause of this patient's hypercalcemia? The answer choices include chronic kidney disease, hypercalcemia of malignancy, milk alkali syndrome, osteoporosis, primary hyperparathyroidism, sarcoidosis, and vitamin D toxicity. Primary hyperparathyroidism. To approach this question systematically, the differential diagnosis of hypercalcemia is best organized by first evaluating the parathyroid hormone, or PTH, level. This allows hypercalcemia to be classified into PTH-dependent and PTH-independent causes. First, PTH-independent hypercalcemia is characterized by suppressed PTH levels. The most common causes in this category include malignancy, vitamin D toxicity, and increased extrarenal conversion of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D in granulomatosis diseases such as sarcoidosis. In contrast, PTH-dependent hypercalcemia occurs when PTH levels are elevated or inappropriately normal despite elevated serum calcium. In clinical practice, this pattern is most often caused by primary hyperparathyroidism, or PHPT. In this patient, we see elevated serum calcium accompanied by a markedly increased PTH concentration. Taken together, this biochemical pattern is most consistent with primary hyperparathyroidism. Under normal physiologic conditions, rising serum calcium levels suppress PTH secretion through negative feedback. However, in primary hyperparathyroidism, PTH secretion becomes autonomous due to the presence of parathyroid adenomas or diffuse parathyroid hyperplasia, and as a result, PTH remains unsuppressed. Many patients with this condition present with mild or even asymptomatic hypercalcemia. Nevertheless, common clinical manifestations include nephrolithiasis, decreased bone mineral density or osteoporosis, gastrointestinal symptoms such as nausea and constipation, and neuropsychiatric complaints. These classic features are often summarized by the phrase stones, bones, abdominal moans, and psychic groans. Serum phosphorus levels are frequently normal but may be reduced in more advanced disease. Now, briefly addressing the incorrect answer choices, choice A refers to secondary hyperparathyroidism, which results from chronic hypocalcemia, most commonly in the setting of chronic kidney disease due to impaired phosphate excretion and reduced synthesis of 1,25-dihydroxyvitamin D. In these patients, serum phosphorus is typically elevated and calcium is low or low normal. Although prolonged secondary hyperparathyroidism can progress to tertiary hyperparathyroidism with autonomous PTH secretion, this would usually occur in patients with end-stage renal disease, such as those on long-term dialysis, and would be unlikely in a patient with only mild renal dysfunction. In addition, tertiary hyperparathyroidism is associated with extremely high PTH levels. Choice B, hypercalcemia of malignancy, is most often mediated by parathyroid hormone-related peptide, or PTHrP, and is characterized by severe hypercalcemia, often exceeding 14 milligrams per deciliter, along with suppressed endogenous PTH levels. Choice C, milk alkali syndrome, results from excessive intake of calcium and absorbable alkali, such as calcium-containing antacids. Although serum calcium is elevated in this condition, PTH secretion is appropriately suppressed. Finally, choice D, primary osteoporosis, is not associated with abnormalities in circulating calcium or PTH levels, which typically remain within normal limits. In conclusion, primary hyperparathyroidism results from autonomous secretion of parathyroid hormone by parathyroid adenomas or parathyroid hyperplasia. The condition is commonly associated with mild hypercalcemia and may present with nephrolithiasis, osteoporosis, gastrointestinal complaints, and neuropsychiatric symptoms. These classic features are often summarized by the phrase stones, bones, abdominal moans, and psychic groans. Thanks for studying with me. See you in the next video.